So happy today to present Dr. Laura Stein from the Department of Neurology. Dr. Stein did her residency, or neurology residency, and stroke fellowship here at Mount Sinai, and med school, right?
Yeah.
And med school here, so Mount Sinai, lifer. And
Wasn't
she
born
she completed her stroke fellowship here as well, and she now focuses on her research interest is on stroke, critical care, quality, and medical education. And she is here to speak with us today about sort of secondary stroke care for the primary care physician. Thank you.
Thank you for having me. I don't have any disclosures. I have an ambitious agenda over the next hour, but I hope that by the end of it, I can convince you that stroke is a huge public health problem, which many of you, I'm sure, are well aware of. I want to update you on some of the opportunities we have for what's now truly life-saving acute stroke treatment. And this is a major paradigm shift really in the last 4 years. I will spend a good deal of time on the latest evidence in primary, but also individualized secondary prevention. We know more now about mechanisms of stroke and have real opportunity to make a change in the natural history of people's disease. And then if there's time, I'll cover a few common clinical questions. As everybody knows, stroke occurs clinically with the sudden onset of a focal neurologic deficit. And it's either because blood flow is blocked or there's a rupture of a blood vessel. The TIA, for all intents and purposes, is exactly the same thing. Thankfully, the symptoms resolve and we don't see diffusion restriction on MRI. But really, we should be treating TIA and stroke patients exactly the same. And in fact, it's our opportunity to really alter the course of the patient's outcome. Unfortunately, what we see is that for most people in our society, it's just that warning of a stroke that's to come, and we're not doing a good enough job of making the appropriate secondary prevention changes. Most of the strokes that we see are ischemic, as in there's a blockage of blood flow. About 13% are bleeding, and the majority of those are in the brain parenchyma itself. About 3%, the minority, are subarachnoid hemorrhage, which I'm not going to spend much time on at all. There are almost 800,000 strokes in this country every single year. It's about 1 stroke every 40 seconds. And it's one of the leading causes of long-term disability as well as the 4th leading cause of death. What's perhaps most concerning is that as we age, we expect to see many more people with stroke. And by 2030, we expect that about 3.4 million more people have had stroke, and costs will triple to over $180 billion relative to 2012. Unfortunately, almost a quarter of the strokes we see are recurrent. And after a stroke or TIA, we see a stroke rate of about 12% in the first year and 25% over 5 years. There are major disparities in outcomes for stroke, and unfortunately, we see a much higher recurrence rate in African American and Hispanic individuals. Now, I want to spend just a little bit of time talking about mechanisms of stroke, because if we have an understanding of why the stroke happened, that's how we can help our patients. And I'm going to try to break it down in somewhat of a easy to understand way. When we think about the culprits of stroke, we can start with the heart. And the heart is the most proximal source of a stroke, or clot to go from the heart to the brain. In most of the patients we take care of, atrial fibrillation is going to be the reason why someone's going to have a cardioembolic stroke, where with stasis of blood flow, we're going to have a clot in the left atrial appendage that's going to travel to the brain. We also see left ventricular thrombi in the setting of reduced ejection fraction, or MI. It's not really clearly shown here, but a small number of strokes are from a paradoxical embolus, going from the venous, the arterial system, right to left with a PFO or a septal defect. And then, of course, valvular disease can be a source of an embolus from the heart. Then we move to the aorta. And the basic concept there is very similar to other blood vessels in the sense that with atherosclerosis, you get plaque, and from the aorta, that plaque can travel to the brain. We then move to the carotid arteries, and we have 2 ways of getting stroke from the carotid arteries. Essentially, as that plaque builds up, we can lose flow through that point, or you can have a plaque travel from the neck into the brain. When we move inside the brain, into the bigger blood vessels here, you can get the same plaque buildup that happens in the neck, or the small blood vessels can be susceptible to the buildup of plaque and cause a different kind of stroke. I just want to make a distinction between the large blood vessels and the small blood vessels, because this is where our paradigm has shifted in acute stroke treatment over the last 4 years. And as you can see on this diagram, the large blood vessels go over the surface of the brain, and they cause very different types of strokes. Strokes that cause things like aphasia or neglect, or problems with the oculomotor system and a gaze preference. The small blood vessels go into the deeper structures of the brain and cause similar symptoms, but you don't get some of those symptoms that are related to the bigger cortical structures in the brain.
Use the pointer or the mouse might be easier.
Okay, thanks. Yeah, so these are the small blood vessels here, and then the large blood vessels going over the surfaces. And we're really looking to change the way we take care of patients with large blood vessel occlusions. We know the cause of stroke in about 65 to 70% of patients. About 20% come from the heart, the causes I mentioned. About 25% are from damage to those penetrating small blood vessels. About 20% are from plaque in the large blood vessels. And then we have a small minority of these more rare other causes. And these are what we think of as the causes more commonly seen in younger patients who don't have traditional atherosclerotic risk factors. Those include things like a prothrombotic state, setting of malignancy or perhaps oral contraceptive use, arteritis from an infectious or inflammatory process, dissection, which may or may not be traumatic, vasospasm, which can often be induced by a sympathomimetic, and with drugs and trauma, which sort of overlap with some of those other causes. Now, there's this category here of cryptogenic stroke. Up to 30% of all strokes, we either don't know why it happened, or we think there are two competing causes of why that stroke happened. And I'm going to come back to that concept because it's changing over time, and we have a new understanding of the majority of these strokes are probably embolic, and we just haven't figured out where that embolus came from, and maybe we should be altering our treatment approach in the future. When a patient is admitted to our service or we see someone in the outpatient center, we have a pretty standardized workup that helps us understand the mechanism of the stroke. We start by localizing the stroke radiographically, and hopefully we've had a pretty good sense from the clinical evaluation. MRI is going to be much more helpful, and we usually get MRI when patients are able to get one. Everyone will have blood vessel imaging of the vessels in the head and the neck. These days, most patients are getting CTA because of our evolution in protocols. MRA is completely acceptable, and oftentimes people will want to avoid giving iodine to patients with renal impairment. I will say that it tends to overcall the degree of stenosis, and there's a lot of artifact. And then transcranial and carotid Dopplers are adequate sources of vessel imaging, but we're doing less and less these days because we're so rapidly trying to detect large vessel occlusion with CTA. Our cardiac evaluation will include at least a transthoracic echo and at least 24 hours of arrhythmia monitoring. In certain patients, we will look a little harder for an embolic source with a bubble study or a transesophageal echo. And then we're doing more and more prolonged arrhythmia monitoring up to a couple years now with implantable loop recorders. I don't want to downplay the importance of assessment of atherosclerotic and lifestyle risk factors. Of course, we need to screen with an A1C and a lipid panel, assess smoking history, hypertension control, and diet and physical activity. So I'm going to walk you through the evolution and how we treat acute stroke. We thought 1995 was a big year because that was when we had the first evidence that we could revascularize patients. We could break up a clot in the blood vessel, restore some degree of blood flow, and improve functional outcomes. And in this original study, we had 3 hours to help patients with stroke. Unfortunately, it takes a lot of time for people to come to the hospital, and many times we don't know when a patient was last well or at their baseline to be eligible for TPA. The effect was modest, and for every 100 patients, about 11 would have no disability or minimal disability. And all of our studies have been measured by what's called the modified Rankin scale score. So how independent is this individual 3 months after the stroke? And we use a cutoff from 0 to 2, because 2 is someone who is still functionally independent, but maybe using a cane or a walker to ambulate. Things got a little bit better in 2008 when we were able to extend the TPA window to 4.5 hours. But again, a lot of patients present well outside of that window or with an unclear time of last known well. 2015 was the year that actually changed everything, and it happened in the middle of my PGY2 years, my first year as a neurology resident. The start of the year, we were only treating with TPA, and then December into January is when things really changed. And this is when we had evidence that opening up a big blood vessel, a large vessel in the brain, like we've done here, results in dramatically improved functional outcomes at 3 months. Now, I'm just going to point out, before we treated people with thrombectomy, opening up that blood vessel, the rate of accumulation of disability was dramatic. So if patients had a large vessel occlusion and we didn't open it up, every single second, 32,000 neurons were lost, and aging was accelerated by 8.7 hours. That was quantified per stroke to accelerate aging by 36 years. So the people who had this kind of stroke were really disabled from it. These are people who would be bedbound, probably have a peg, and really have questionable, meaningful quality of life after one of these kinds of strokes. I just want to point out from a sort of larger societal public health standpoint, large vessel occlusion stroke only accounts for maybe 20, 25, up to 30% of all stroke types. However, it does cause a disproportionate amount of the disability and death. And people are trying to quantify this exactly to make a case for various public health efforts around this, but some have estimated that it accounts for 3/5 of dependence and about 90% of mortality after stroke. That's all stroke. So when this trial was published in 2015, they were looking at, again, this outcome of functional independence at 90 days. And all of these trials have been set up in the same way to show the shift in the number of people who are functionally independent at 90 days. And the adjusted odds ratio was about 1.6 in favor of treatment with thrombectomy. And you can see that it was about a 13.5% difference in the percentage of patients who were functionally independent at 90 days. We thought this was incredible, and here at Mount Sinai, we did a ton to try to promote bringing any possible patient with a large vessel occlusion over for evaluation in case they had a salvageable brain at that point. So again, at this point in time, we had 6 hours to take out a blood clot in people who had a blockage of one of the big blood vessels in the brain. And then in 2017, we had Dawn. And we've sort of dubbed this the dawn of a new era in stroke care. This looked at what can we do up to 24 hours from last done well, or in patients who have an unclear time of last done well. And the key to this is we have to figure out who has brain that is at risk of dying but hasn't yet died. The terms that we use are a salvageable penumbra. And this does require advanced imaging with scans that are looking at blood flow dynamics. There's a move to maybe do a little more of this with MRI, but for now we're using what's called perfusion imaging for these kinds of patients. As good as we thought the previous trial results were, these were even better. And early because at the planned interim analysis, the results were so positive, but the difference in percentage of functional patients was over 30% at 90 days. So that's this group here who is still independent after this major disabling stroke. I just want to point out the number needed to treat from this trial is 2.8. There are very few therapies in all of medicine who have such a small number needed to treat. And we have up to 24 hours to deliver this therapy to a select group of patients. Our guidelines evolved very rapidly to reflect this. We have level 1A evidence to treat people within 6 hours without that advanced imaging. And then we also have level 1A evidence to treat people up to 24 hours with a large vessel occlusion. So here at Mount Sinai, our protocol is very much geared toward rapid identification of large vessel occlusion. Anyone who comes in with a last known well of 24 hours or unclear last known well will be called as a stroke code. They will get a CT as well as a CTA head and neck, regardless of renal function. I think we've been able to convince people that the incidence of contrast-induced nephropathy is not that high, and we can really help a lot of people if we give them a little bit of contrast. We are using perfusion imaging or MRI after 6 hours to find out if people have salvageable brain. And the current standard of care here is to give TPA up to 4.5 hours from last done well in patients who don't have a contraindication. And there's actually some fairly exciting new evidence that we can probably treat people in longer windows using MRI. And The guidelines actually updated yesterday, and the American Heart Association is endorsing that in certain situations. There are also some evidence that we may have a new thrombolytic tenecteplase to use in the near future, and it's being used in MI. We can give it more quickly, and also it's less expensive. So we'll see how that plays out in this country. A lot of the studies were in Europe. And then the last part of our protocol is that we're going to offer mechanical thrombectomy in patients who have a large vessel occlusion and salvageable brain. The one caveat there is that they need to be functional at baseline. We don't, there's not evidence to offer this to patients who are dependent in their daily living at baseline. Now, the policy statement this past year sort of took a new stance, and it was less about the effectiveness of the therapy, that's very well established, but how do we get patients to this life-saving therapy? So it's all about systems of care, and this is what I'm really interested in from a research standpoint personally. What it's highlighted is early recognition in the field. So there are multiple scales that have been validated to detect large vessel occlusion. These are scales that are easy to administer and done by EMS in a very short period of time. Once patients have been identified as potentially having a large vessel occlusion, the American Heart Association says that they should be taken to the closest thrombectomy capable center, not just any stroke center in this country, those places that could pull the clot out if it's there. They've given a recommended travel time of under 15 minutes, although that's something that's being debated. And they do point out, importantly, that we do need a lot more research about what our systems of care should look like and how these algorithms can help as many people without harming those not eligible for therapy in the process. In New York City, we have taken this very seriously. In April, EMS, there was a brand new protocol for EMS to follow for stroke triage. So any patient that gets called as a possible stroke will receive this Los Angeles Motor Scale plus speech. It's what we call the New York City SLAMs. Very simple assessment. Do they have a facial droop? Do they have an arm drift? Do they have a speech deficit? And what's their grip strength like? If they score a 4 or more, and they don't have exclusion criteria, they will go to the closest thrombectomy center. I just want to point out the exclusion criteria include someone who is wheelchair bound or bed bound, because presumably they don't have a functional status to warrant therapy. Someone whose last done well is more than 5 hours. That's a little bit controversial because we can help people well beyond 5 hours. And then they're supposed to go to a center within 30 minutes. As we all know, it can take 30 minutes to go 10 blocks in New York, but they're collecting a lot of data on this. Here at Mount Sinai, we do an incredible number of endovascular cases, and I'm actually just curious, have any of your patients been treated with mechanical thrombectomy that you know of? Okay. Plenty of IMA patients have. Our numbers are going up, and you can see that in 2014, we really weren't doing much of this therapy because we just didn't have the evidence to do it, and since 2015, numbers have gone up. You'll notice in 2019, our numbers are a little bit lower, and that's a good thing for 2 reasons. So one, we can now perform thrombectomy 24 hours a day at 5 of our health system hospitals. So we don't need to transfer. And the other is that in April, they went live with that triage protocol. So patients are being taken to the appropriate hospitals initially and not having to come to us. So that's better for patients, and we'll see what the volumes do long term. Just to talk a little bit about our outcomes, we tend to be fairly aggressive with the patients who we treat, and so we treat a lot of patients who are on that sort of border of not being quite as independent as they were in the clinical trials. But despite that, we are seeing that over 33% of our patients are in this 0 to 2 functional status. So they are independent after their stroke. Now, one of the concerns that we have is that the rest of the country doesn't look like New York City. And one of my favorite lines is, where you have a stroke matters. I feel very strongly about this, and we're incredibly lucky to take care of patients with the resources that we have. But what we're seeing is that even though rates of treatment with both TPA and thrombectomy are getting better, only about a little over 3% were treated with thrombectomy at the end of 2016, which was 2 years into the data. Now that doesn't reflect this 24-hour window, and we hope that these rates are better. But we have a long way to go with acute treatment of both TPA and thrombectomy. The TPA number is about 9% nationwide and just under 4% for thrombectomy. This is using a nationally representative administrative database. Now, obviously, I'm speaking to a room full of people who believe in the power of primary and secondary prevention, as do I. the best treatment for stroke is prevention. So we'll transition more to prevention side. And I want to start by just saying, we know why people have strokes. Unfortunately, we don't know all the people who have high blood pressure and other risk factors for stroke to be able to treat them. And when you look at stroke on a global scale, the global burden of disease, none of these results are going to be surprising to anyone in this room. A huge percentage of the stroke that we see is from modifiable risk factors. And that's in some ways encouraging to all of us because there's a lot we can do. And not surprisingly, globally, high blood pressure is the greatest modifiable risk factor. And when you look at high-income North America, that's number one. Number two is high BMI. Again, no surprise to anyone in this room. Diet comes in at 3 and 4, and then smoking at 5. Now, we have a lot of opportunities to, as I keep saying, alter the course of patients' outcomes. TIA is that perfect example. We say that about 15% of all strokes are preceded by a TIA. Question is it recognized as TIA, and is the appropriate treatment implemented? In the largest study of TIA patients, which was done out of Kaiser system with over 1,700 patients, they looked at rates of stroke in 90 days. Over 10% had a stroke in 90 days. And what you can perhaps see here is that the highest rate of stroke occurs in the first 48 hours. Half of these patients had that stroke in the first 48 hours. And the more risk factors patients have, the more likely they are to have an event, not surprisingly. In this study, they looked at the independent risk factors for stroke within 90 days. And you can see age, diabetes, a longer episode, so longer than 10 minutes, an episode that had weakness, and an episode that had speech. All of those things were associated with risk for stroke within 90 days. And again, just that point, the more risk factors patients have, the more likely they are to have a stroke. This study is the basis for an ABCD2 score, which some of you may be familiar with. It's what we're using somewhat to stratify risk of TIA. And the thought is that in patients who are high risk with an ABCD2 score of 4 is what the study has said. In our hospital, we use 3. We should be admitting those patients to monitor them for 24 to 48 hours. And our protocol does do that for patients even perhaps a little bit lower risk with an ABCD2 score of 3. And just to give you a sense of what's really important in these patients, we want to make sure that there's no impending carotid occlusion or impending severe embolic event. We want to make sure that there's not a cardiac arrhythmia that we should be treating. And they don't need occupational therapy. They don't need to stay in the hospital very long. We want to start that transition of care with good outpatient follow-up so that they can work on their modifiable risk factors. And in our protocol, patients will get the echo from the observation unit. They're on tele. And the only reason we would admit them is if there's a critical finding on the echo or on their carotid imaging. Yeah, please ask anything.
So if we see someone cleared up with the TIA, less than 48 hours, sounds like we should set them up. What if someone describes like a TIA a week ago, do we do like aspirate like platters for the 90 days or whatever? And like, is there any reason to send them to the hospital just do all that work of echo, ultrasound, as that?
I mean, I would say the most important test to get right away is I would send them for a CPA, head and neck. But it's really clearing the carotid artery because you don't know who has that critical stenosis that's just getting enough flow or has an unstable plaque that's about to rupture. And then, chances are you can fairly quickly get an echo, and the arrhythmia monitoring is also the important thing. So it's a little bit of a judgment call as far as how quickly you can get those studies done.
Yeah. And like, is there, like a time period after which like the risk of so that we might as well like do those things like slower outpatient?
Yeah, I mean, the risk is definitely highest in the first 48 hours, goes down, after a week, but still out to 90 days, it's not insignificant. Yeah. And we're actually trying to work on something in our division where we want to have one provider available for same-day evaluations. We're not quite there yet, but generally, if you email one of the members of our division, we can find someone to see the patient, get the workup done quickly, and work with you. And then, don't hesitate to send them in. I think that should always be the message. Don't hesitate to do that. So we're going to talk about some other places to sort of modify that risk factor profile. And Kenny, this is probably going to apply to the patient population you're describing. So patients who have a high-risk TIA, that ABCDG score of 4 or more, they have what looks like a stroke, they get all better, there's nothing on their imaging, or patients who have a minor stroke, as in we see the stroke on the MRI, but they're minimally affected, we have pretty good evidence that we should be treating these patients with a short course of dual antiplatelet therapy. And this trial was a follow-up study of one that was done in a largely Asian population. This was done here in the United States. And these patients were randomized to a Plavix load plus aspirin, actually for 90 days, compared to aspirin monotherapy. And what they found was that the composite of stroke, MI, or death from ischemic vascular causes was lower, the hazard ratio of 0.75. But they found that in terms of safety, they were seeing higher rates of bleeding. And major hemorrhage was more common. What I would point out to you is that there was no difference in intracellular hemorrhage. Now, obviously, you guys care a lot about GI bleeds in probably ways that I don't care quite as much about. And I realize that for patients' quality of life and adherence to secondary therapy, those are really important events. But I want to convince you that despite what some people call a negative trial, which I take great issue with, there's really good evidence for a short course of dual antiplatelets. And the reason for that is essentially in these two graphs here. So this is the percentage of patients with an event in the dual antiplatelet therapy and the single antiplatelet therapy event. You can see the slope is pretty steep early on, and then it levels off. So this is 7 days here, okay? And when you get out to 30 days, it's fairly flat. So really, we want to be treating people as quickly as possible. Now let's offset that with the risk of hemorrhage, and you can see that pretty early on, these curves are fairly close together, and then they start to separate the farther you get past 30 days. Yeah?
So can you just clarify, is that the second event happening? In other words,
correct.
At time 0, they have the TIA with a minor stroke.
That's right. That's a recurrent event. Yep. So this study, as I mentioned, was a follow-up to another study where they only gave a shorter duration of therapy. And the combination of lower bleeding events in the previous study plus this clear change after really 30 days in terms of benefit and risk has prompted most stroke neurologists and the American Heart Association to say 21 days of dual antiplatelet therapy for these kind of patients. And what you have to think about is this a stroke due to a cardiac embolus? Well, if that's the case, you don't want dual antiplatelet therapy at all. Or is this other causes of stroke that are more related to atherosclerotic disease? And that's really who we're targeting in this kind of a trial. One of the things I don't go through at all in my talk is the importance of high-intensity statin. It goes without saying, all these patients are going to put on high-intensity statin as well. And obviously you guys are very familiar with all the evidence around high-intensity statins. But as I said just yesterday in the updated guidelines, the American Heart Association does endorse 21 days of dual antiplatelet for these patients. Yeah.
So I think this came up in one of our journal clubs. The clopidogrel load
Yes.
they did, most of the time you see folks well beyond the
Absolutely.
period. So can you just start them on the 7-by-1?
Yeah, I'm glad you asked that question. Yes, the load is really most beneficial in the acute period, and in the other trial that I'm not mentioning is the CHANCE trial. They gave the load within 24 hours, and the POINT trial was within 12 hours. So what we typically do is within 24 hours we load with the Plavix and then give the dual antiplatelets for 21 days. There are some people who say, well, why am I going to give dual antiplatelets 7 days out? I mean, I see that point as well, but if we're doing a short duration of therapy and we think there's benefit out to 21 days, I think it's reasonable to do dual antiplatelets without a load, even if it's 7 days out. Yeah.
So you only load for the first one.
That's correct. And obviously these are all individualized decisions, and you're weighing risk of bleeding with the risk of recurrent stroke. That's a great journal club topic. Okay, so we have another mechanism of stroke that benefits from dual antiplatelet therapy. So that's now when we're moving to atherosclerotic disease of the big blood vessels. Before we were talking about a lot of strokes with atherosclerotic disease of these smaller blood vessels. Now it's same concept, but different blood vessels. This trial was done, it was published in 2014. It was looking at stenting. So putting patients through a procedure when they had symptomatic stenosis of the large blood vessels inside the the head and the neck. And this trial was actually stopped early because there were very high rates of stroke with stenting. But they wanted to follow up the patients long term to see how they did with medical therapy. And what was most unique about the study was the degree of lifestyle coaching patients got. They all got life coaches who helped them with their smoking, with their diet, with their diabetes control. And I think that's actually the most impressive part of this study was how well controlled people were for 2 years. So the goal systolic blood pressure was less than 140, and in patients who were diabetic, it was less than 130. And you can see both arms got medical management, and we have a pretty large percentage of patients who are at goal. And then as far as LDL reduction, they wanted to see an LDL essentially of less than 70. And patients really, they did a pretty good job of that, considering the lifestyle changes that have to go into that. And at the end of this, these numbers aren't all that important, but medical therapy won out, and there was no difference in the, well, actually, there was more bleeding in the group that had stenting, and they didn't really look at bleeding outcomes in the same way as we have with some of these dual antiplatelet studies, but we extrapolate this evidence to say that patients who have large atherosclerotic disease plaque of their blood vessels should get 3 months of dual antiplatelets plus a really intensive lifestyle modification. And you know, there's a lot of debate about which actually improved results in this study, and it's probably the lifestyle modification as much as it is the dual antiplatelets. But no stenting, that's for sure. Okay, so now we're going to move to the neck, and we're talking about atherosclerotic disease that's symptomatic. Okay, as in this patient has a plaque here and a stroke on the same side of the brain. Okay, there's a lot of asymptomatic carotid disease out there. This is very clearly symptomatic carotid disease. For a little while, we've known that patients who have this symptomatic plaque of at least 70% in the carotid benefit from intervention. And for a while, we were just doing carotid endarterectomy, but we had a change in the paradigm in 2010 when we had evidence that carotid stenting was really probably just as effective and just as safe as carotid endarterectomy. Now, I'm saying that in sort of broad terms. So the primary endpoint, which was any periprocedural stroke, MI, death, or a post-procedural stroke on the same side, there was no significant difference in that hazard ratio. What is important to note is that there were some differences in MI and in periprocedural stroke. And we saw lower rates of MI in patients who underwent carotid endarterectomy and higher rates of periprocedural stroke in patients who underwent carotid stenting. And some of that is procedural technique, and our interventionists would tell you, oh, our technique is so much better, our rates of periprocedural stroke are lower. But you do have to have a fairly nuanced conversation about choice of intervention. And there's some additional data that's worth noting, which is age seems to perhaps play a role here, and 70 is sort of the cutoff point. Patients who are older than 70 may do a little bit better with carotid endarterectomy, and patients who are younger than 70 may do better with stenting. So these should be sort of interdisciplinary conversations about the best approach to treating symptomatic carotid artery disease. And again, 70% is that sort of magic number. Question is, what do we do with people who have asymptomatic carotid artery disease? And the answer is we don't yet know. There is an ongoing clinical trial which we're actually enrolling for, CREST-2, the previous study was CREST, and they're randomizing patients to maximal medical management versus stenting versus endarterectomy. And we will see. These are patients who have 70% stenosis or more and have not yet had a stroke on that side.
Have been previous trials already shown that medical management is
right.
superior?
Well,
Why is
the argument is that it wasn't actually maximal medical management and it wasn't actually maximal procedural technique in these therapies.
So how have the procedures changed?
They have better, what are called embolic protection devices that they use. And then also, what's happened is these procedures are doing so many acute stroke cases that they're just, in theory, getting a lot better at doing these procedures and causing fewer strokes in the process. So we'll see how it plays out. Everyone is anxiously awaiting that. But you know, it comes up all the time where patients come to us and ask what we should do. And we certainly, on the stroke neurology side, are not encouraging any intervention on asymptomatic carotids. Okay, a little bit on cardioembolic stroke. I'm not going to spend too much time on this because I think, you know, obviously you guys are as knowledgeable about DOACs and ways to anticoagulate patients as anybody. Probably we're getting better and better at preventing stroke from AFib because the DOACs are pretty good and they're easy to take. We are getting more evidence to suggest that maybe in patients who are younger and have a PFO, maybe we should close that PFO. Now, that data is sort of being debated and the guidelines are still being developed, but the more that it's meta-analyzed, it seems fairly convincing that younger people who have a stroke that looks like came from the heart and don't have traditional risk factors like diabetes, hypertension, hyperlipidemia, those patients may long-term benefit from closing that PFO. Okay, cryptogenic stroke. So imagine being one of those 20 to 30% of people who are told, well, we don't really know why you had this stroke, but we hope you don't have another one. It's very disheartening to patients. They become very concerned about the risk of future stroke. It's hard to convince them that the risk of recurrence is actually fairly low in this population. Doesn't matter. So these are the patients who, they really think they look like they're an embolus from somewhere. We just don't know where that is yet. We do a lot for these people. We look at their blood vessels with very high resolution vessel wall studies. We do hypercoagulable workups. We make sure they don't have that PFO. And we do a lot of prolonged cardiac monitoring. I'm sure you have plenty of patients who had loop recorders placed after a stroke, and those loops stay in there forever, and a lot of times they don't show anything. And there's a lot of debate about how long we should have them in. They're expensive. Are they changing the management all that much? That's being debated quite a bit. A lot of the push for that stemmed from a couple studies in 2014 where we were seeing higher rates of AFib and cryptogenic stroke. Now, one of the things you have to ask is, how long does it have to last, and how often does that happen to truly be the causative mechanism? So if someone is found to have AFib 2 years after their stroke, did that really cause their stroke? Hard to know, and this is being debated. So we're seeing a little bit of a paradigm shift in how we think about this. There's this new concept of embolic strokes of undetermined source. And this has gained traction as sort of a subset of the cryptogenic stroke. So again, these are people we think, that had to have come from probably the heart or some other embolic source, but we just don't know where yet. And the reason I bring this up is because for a while we were thinking, let's just anticoagulate all these people. The DOACs are so safe, of course they'll do better. The first study that sort of refuted this was Navigate ESUS using rivaroxaban. Wouldn't have been my first choice of DOAC to use for this study, but what they found was that there was no difference between rivaroxaban and aspirin, and then we saw more bleeding events in the rivaroxaban group. This was followed up with Respect ESUS, and this is with dabigatran. Again, would not have been my first choice. There was notably a difference in bleeding events in this, in clinically relevant non-major bleeding and major or clinically relevant non-major bleeding. So then we started to say, well, maybe it's not really the AFib that's causing the stroke. Maybe the AFib is a marker of atrial dysfunction that has been termed atriocardiopathy that's really driving the stroke burden in these patients. So that's the current thought among neurologists, that this atriocardiopathy can both be identified and treated. And so what they've done a good number of studies looking at the degree of atriocardiopathy in these embolic strokes of undetermined source. And some of the things that they're seeing is that these patients are younger, have lower rates of hypertension, higher cholesterol and LDL levels, but perhaps had fewer left ventricular and atrial abnormalities compared to cardioembolic strokes. And so what they've come up with is a series of,
What's the mechanism by which atrial cardiopathy will cause stroke if not
via AFib. So I have to admit that this is not my area of expertise at all. There are lots of theoretical mechanisms that have been invoked, including a sympathomimetic response to it. It has to be played out in large-scale trials to actually gain traction at this point. Yeah.
And do they have some criteria with this diagnosis where they've ruled out, a cold AFib? Now we have, implantable loop recorders and better ways of seeing that, once every 6 months you're actually going into AFib.
Right. So the Arcadia trial is the trial that is most actively looking at this. And I mean, you can actually put someone in this trial who has a loop recorder in. So we don't have good criteria because we haven't truly defined what this atrial cardiopathy is. What some people think that it is, manifest by, is changes in the P wave terminal force on EKG, elevated serum NT-proBNP, and then a left atrial diameter that is greater than or equal to 3 centimeters per meter square on echo. And of course, they don't want to be putting people in this trial who have known AFib or contraindication to anticoagulation. We'll see if this plays out. I mean, this is the first trial where they have tried to stratify based on the degree of atrial dysfunction or atrial cardiopathy. And this is being done with Eliquis as opposed to the earlier DOACs. And, we're as anxious as anybody to see if this is actually a positive trial. Are you going to ask a question? Okay. There are some people who would say, I'm going to anticoagulate these people anyway and wait for that loop. And if after some arbitrary time point there's nothing on the loop, then I'll stop. Some people would say, maybe this is due to occult malignancy and hypercoagulability that just hasn't been picked up, and maybe we should look more there. We really don't know, and in my opinion, this is sort of the area that we need to learn the most about in stroke to help more people, because so many of these patients have this cryptogenic etiology. Now, there are a few clinical questions that seem to come up when we intersect with internal medicine, and one of the most common ones is, when can we restart anticoagulation after ischemic stroke? The reason why this is such an issue is that dead brain tissue is at risk for bleeding, and so when we anticoagulate people, we risk causing hemorrhagic conversion of that infarct. As a fellow, I was always told, 48 hours to 2 weeks to a month. We're actually getting more data for this, right? Not helpful. And there have been more studies looking at starting anticoagulation in the first 3 to 5 days. It looks pretty promising. In the latest guideline statement, the American Heart Association is saying 4 to 14 days. Not so helpful. But what we think about is, how big is that stroke? How high is that risk of bleeding? And then what is the indication for anticoagulation? And boy, if someone has a valve, they're going to be on a heparin drip from minute 1 after their stroke. Maybe not, depending on the size of the stroke. Now that we're treating some people with thrombectomy, the size of the stroke is much smaller for a lot of these people. And those are the people who have AFib, okay? So those are the people we may start Eliquis within 24, 48 hours in the hospital because the size of the stroke is so small and the risk of bleeding is probably fairly inconsequential. The next one that comes up a lot is, should we restart antiplatelets or anticoagulation after an intracerebral hemorrhage? All the time. And we're getting more data on this. There was actually a randomized trial called Restart, where they looked at restarting antiplatelets and anticoagulation, people who had a clinical indication for these medications. And I mean, this was a fairly small trial, but it's the first that, sorry, I guess I didn't really go into the, essentially people who needed to be on these medications didn't have a dramatically increased risk of future recurrent intracerebral hemorrhage. And so I think we have to go back to, why is this patient supposed to be on antiplatelet or anticoagulation in the first place? And it's just weighing the risks and benefits. We typically wait 24 to 48 hours to restart aspirin in people who really need it. And then the American Heart Association is recommending that you wait at least 2 weeks after a hemorrhage. 4 weeks, I'm sorry. They're saying at least 4 weeks in patients who need anticoagulation. And what's interesting is they mention warfarin probably should be avoided in people who've had a bleed, and these are people who have non-valvular AFib. And then they also say that it's class 2B, level B evidence for resuming these agents. And they acknowledge they don't know how useful the DOACs are compared to warfarin in these patients. The next one that comes up a lot is, does a low LDL actually increase the risk of intracerebral hemorrhage? And I didn't go into this data in any great detail. I just want to tell you a lot of that is, it's secondary analysis. It is purely association. There's no evidence of causation. And the American Heart Association just says that there's no data to recommend that we not give statins to people in ICH. And again, I would go back to, do these patients have a need to be on a statin? And yes, most of them do, and we should be going for aggressive reduction in these patients when it's indicated. So I would encourage you not to stop statins just because someone has had a bleed.
What about decreasing the intensity of?
Yeah, we do that. It makes us feel better. Yeah, it makes us feel better. I mean, I do it. I have colleagues who stop it, who, people do all kinds of things. I don't think it's an unreasonable approach to it, but who knows what it's actually doing other than making ourselves feel a little better. I think with all of these decisions, I would go back to what is the primary indication for that high-risk medication in this patient. And if it's a strong enough indication, then probably we should be continuing them in some fashion. And then the last one that we get a lot is, now that we have all these DOACs, what are we doing to reverse patients who have a bleed? And this has evolved in the last few years. So the first is patients who come in on aspirin. Should we be giving them DDAVP and platelets? At the start of my training, we were giving platelets, and then the patch trial came out and basically demonstrated that unless patients were going for surgery, which is the minority of intracellular hemorrhages, they actually do better if we don't reverse, and if we don't give them platelets. We give them DDAVP, and boy, we see a lot of hyponatremia after we do that. So it really has to be a clinically significant bleed, in my opinion, to warrant that. We do have a reversal agent for dabigatran. Plaquenine is the commercial name, or intracranial, and a lot of hospitals in this country don't carry it, but we certainly carry it here, and we can give it to reverse. And Andexanet alpha has gotten a lot of attention of late for the 10A inhibitors, and the Portola, the company that makes this reversal agent, is really pushing it among our community, trying to get us to endorse the data. I will say that, especially in the early data, there were high rates of thrombotic events in these patients that were very concerning to us. And the more recent, longer-term data is maybe suggesting that patients who have high factor 10A levels, as in they recently took their agent, they may do a little bit better with Andexanet alpha than just giving them PCC. But I still have a little bit of concern about the high rate of thrombotic events. And so I can tell you here, we've had a lot of conversations both with the drug company and the hospital committees about this. We do not yet carry it because, one, the data is a little bit concerning. Two, it's very expensive. And three, it takes a long time to actually mix it and administer it. We can give PCC incredibly rapidly, and it probably does reasonably well without causing too many adverse effects. So that's how we're doing it right now. But I am afraid that the FDA gave an expedited approval. I think we're all going to be using it in a matter of time, and we're probably not going to be able to keep using PCC in these patients. So I'll wrap up at this point and just remind everybody, stroke is a huge cause of disability and death. We have a lot of great acute treatments and really great opportunities for individualized secondary prevention. Most important thing is, if anyone's concerned for stroke, get them to call 911 and try to get them to the closest stroke center, because that can be life-changing. We do have this acronym BFAST to help remind patients of signs of stroke and also the importance of time. Interestingly, the American Heart Association only uses the FAST part of this acronym, and there's a nice study that demonstrated you miss about 14% of people. Here at Mount Sinai, we do use BFAST, the whole acronym. B is for balance or incoordination, E is for eyes, so loss of vision or double vision,
Like
F is for facial droop. What's that?
Like a new balance.
A new balance, right? So all of these are acute onset of a new deficit. Yes, yes.
New balance.
But we all, have a role to play in trying to get people access to acute stroke therapy. And time will always be brain, no matter how much time we have to treat people. Happy to take any questions.